This is a lecture on the subject of endometriosis. It's a very common condition in women, and over the next few minutes we'll discuss this widespread condition. What is endometriosis? Well, endometriosis is the presence of endometrial glands and stroma outside the endometrial cavity and outside the uterine musculature. When endometrium is found deep within the musculature of the uterus, within the myometrium, it's otherwise known as adenomyosis, but when it's outside the musculature and outside the cavity of the uterus itself, it is called endometriosis. It's thought that 90 to 100 million women suffer with endometriosis around the world, and it's said to occur in somewhere between 3 and 10% of women during their reproductive age. That number is higher again in women who are experiencing infertility issues. Most women that we treat are within the 30 to 45 year old group, but it's not unusual to find it in young and even adolescent women. And there doesn't seem to be a difference between women of different races. This is kind of demonstrating the areas that we commonly find endometriosis. It can be found on the bowel, it can be found even in the umbilicus, widespread throughout the peritoneum, over the uterovesical fold. It can be found on the appendix, fallopian tubes, on the ovaries, and within the ovaries can create ovarian cysts. It can be found on the ureters, it can narrow the ureters, on the sigmoid colon, and a lot of times it's in this area, the rectovaginal septum, and also the pouch of Douglas. Now, there's a few theories as to why it occurs, and I think those of us that have been deal quite a bit in this area believe that the theory of Sampson from the 1920s, where endometrial fluid or effluent, as well as passing out at times of menstruation, also that fluid passes back through the fallopian tubes and is implanted within the peritoneal cavity. Women that we find that have Müllerian anomalies and other outflow obstructions are far more likely to have this. And I suppose it could be seen as a physiological phenomenon, but I think some other factors have to be correct. So we're not quite sure, is there a difference in the endometrium in these women as to whether their immune response is different, and whether the peritoneal surfaces are different in these women. Also, endometrium has been found within scar tissue, and some have questioned why it may be present in extragenital areas, but that could be because of lymphatic or hematogenous spread. It can be found in the diaphragm. Lesions are said to be found in the liver, in the lungs, etc., and in the brain indeed. But I think most people would agree with Sampson's theory that it is because of retrograde menstruation, and the correct factors must be present. Another theory from Mayer in 1919 would have suggested that there's metaplasia occurring within the coelomic epithelium, and that you get changes there in the right hormonal circumstances where endometrial glands sort of come to be. But it may also then help with the theory that the rectovaginal septum, where you often find endometrial glands deeply embedded, it can only be there because of metaplasia. But again, I don't believe this is the case, but these are the theories. So there is a genetic element. It is 7 times more common in first-degree relatives. It is more common in monozygotic than dizygotic twins. And also there seems to be in some women a decreased cellular immunity. In North Italy, in the Po Valley, where there's a lot of heavy industry and there's said to be a lot of atmospheric or environmental dioxins, again, this is a theory behind the reduced immunity that some of these patients have. So overall, there seems to be a theory now whereby there is, sort of the mechanical flow of menstrual effluent back through the tubes in the right endocrine setting leads to implantation of the peritoneum, which then creates the endometrial implant. On the other side, you know, whether genetics or immunology together result in metaplasia may not be may not be the reality, but I think the main thrust, or the main theory, being that retrograde menstruation, in the presence of immunological factors and genetic factors, so there's an overlap between these. There may be progression and worsening of the disease where then it does implant and also becomes quite invasive, and may then go on to lymphatic and blood spread. So this is kind of the current theory as we see it. Well, what do we see? We see scarred areas, white areas, red lesions, clear lesions, neovascularization, so you see new blood vessels growing in and around the lesions. So these are the kind of the typical lesions as we see them. These deep black scarred areas or powder burn marks are often what we see too, and a lot of inactive glands with these sort of redder areas have active lesions within them. Again, this image just highlights you know, the sort of the new vessels and the black powder burn lesions, and also other active lesions around. So that's what they look like. Again, more images of the same. Red endometriosis, black endometriosis, etc. This causes pain and scarring, and new nerve ingrowth has been found in these lesions, probably contributing to the pain. As I alluded to earlier, when endometriosis occurs on the ovary, chocolate cysts or endometriomas may occur, and it contains hemosiderin, which gives it the brown to black color, and it contains blood primarily, or the hemosiderin laden material, and occasionally some menstrual debris from the endometrium that's lining these cysts. Again, under the microscope, when examined, you'll find the glands and stroma with the blood and other cystic elements. Some endometriosis is described as stromal, and I'm only throwing this into the talk to say that there's a highly aggressive element of this, and it may actually be locally malignant. This is rare and really shouldn't come into your thoughts, but again, just from a discussion point of view, endometriosis has several forms. How do we stage endometriosis when we find it? Well, it's staged based on the revised American Society of Reproductive Medicine staging, which shows that stage 1, it's minimal. There's a few superficial lesions on the uterus or on the fallopian tubes or on the ovaries. Stage 2, again, there's more implants, totaling less than 5 centimeters overall when you add all the measurements together. Stage 3, then, there's multiple lesions with implants that are invading, also tubal disease, and adhesions may occur. And then stage 4 is severe disease with endometriomas, and the adhesions are dense, and the ovaries may be fixed to the back of the uterus or the pouch of Douglas. Also, they may be adherent to each other. I suppose we use staging in an attempt to look at fertility, because there is no relationship between the degree of disease and the amount of pain that a patient experiences, but certainly we know that the lesser stages have a better reproductive outlook. It's often misdiagnosed. Cyclic pelvic pain may be put down to just dysmenorrhea, cyclic dysmenorrhea. But for a lot of women, the average time to diagnosis seems to be about 9 years. And during this time, there probably is a progression of the symptoms, and also infertility rates might be increasing during this time. So I think we should probably have a lower threshold for diagnosing this at an earlier stage. So it often causes dysmenorrhea, lower back pain, pelvic pressure. It may be associated with menstrual irregularities, but in itself doesn't cause menstrual irregularities, and certainly infertility may be another feature. If the lesions, like this one here demonstrated, is on the bowel, it may cause, if it fully penetrates through the bowel wall thickness, may cause cyclic rectal bleeding, tenesmus or sensation that the bowel isn't full, painful bowel motions, and occasionally cyclic diarrhea or cyclic constipation. If the lesions occur in association with the urinary tract, rarely there may be hematuria. Also there may be pain while voiding, and on occasion you may have ureteric obstruction, which results in swelling of the renal pelvis and pain, flank pain from this, but that's rare again. Occasionally you can get patients with cyclic hemoptysis and blood-stained pleural effusion, and there's a very rare condition called catamenial pneumothorax, where the endometriotic lesions seem to contribute to the development of pneumothorax. This again is a lesion, a kind of a deep purple black lesion within the umbilicus, which may cause cyclic pain there, and I've seen a few cases of that over the years. So overall, when looking at the symptoms, 60 to 80% of women with this condition will have dysmenorrhea. Up to half will have pelvic pain on an ongoing basis. It is definitely associated in a large number of women with infertility. Lesions, especially in the pouch of Douglas, may cause painful intercourse. There may be irregular cycling in these women, and then in rare cases you may have rectal bleeding and pain with opening bowels and things like that. To clinically examine these patients, you might find tenderness in the pelvis. The uterus may be in fixed retroversion. So for women with an unfixed retroversion, the uterus will be mobile, but in the cases of endometriosis, it may be fixed. There may be nodularity or lesions within the pouch of Douglas, which will be palpable, and also if there's endometriomas, the ovaries may be enlarged. Again, as we said earlier, there's a clear association between infertility, but what exactly that relationship isn't quite well known. But the endometriosis is found in large numbers of infertile women. Why this occurs? Well, there may be increased levels of activated macrophages in the peritoneal fluid, interleukins and prostaglandins, and tumor necrosis factor is also found in the peritoneal fluid of women with endometriosis. There's also anti-endometrial antibodies in these women. It seems to be luteal phase dysfunction, abnormal follicular growth, premature LH surges, and I think all of these factors will lead to decreased oocyte function, decreased tubal function, and overall infertility. Then as the peritoneum becomes increasingly diseased, more and more pelvic adhesions form, and these then will provide a mechanical issues with respect to oocytes passing to the fallopian tubes and sperm mobilizing through the peritoneal tubes. There may be, I think, a risk of cancer between, in the cases of endometriosis, but again, this may be more hormonal and genetics as opposed to the disease proper itself. What other diagnoses should come to mind in patients like that demonstrate the pelvic pain and cyclic dysmenorrhea? Well, if pelvic infection needs to be outruled, fibroids, tumours that may occur must also be considered, the acute abdomen with appendicitis, etc., and if there's rectal bleeding, certainly tumours in that area should be also considered. The gold standard of diagnosis is laparoscopy, and it allows us to both visualize and stage the disease, but also to treat the condition. Now, the surgery for this is quite specialized, and more and more surgeons now require specialist training for this type of surgery. The lesions can be difficult to deal with, especially when they're in association with various organs, and the disease needs to on occasion be stripped out and peritonectomy performed. Sometimes appendicectomy has to be performed when the lesions are close to the ureters, mobilization of the ureters, etc. Must be performed, so it can be difficult surgery. CA125 levels can be raised also, but it's not useful when screening for endometriosis. But in a small group of patients, it may be useful for identifying women who have had a response either to the surgery or to other medical therapies. Ultrasound definitely will show up endometriomas if present, and also the material within those endometriomas has a certain amount of echo texture to them and can be seen. Other lesions of endometriosis generally are not seen with ultrasound. As I said, because of the appearances of the endometriomatous, there's a sensitivity of about 83% and specificity of almost 98% when looking at these lesions. CAT scans, they have a role, but ultrasound is probably superior. MRI may be useful at delineating and looking at rectovaginal disease down behind the uterus. This is the uterus on an MRI, and in the area behind the uterus, MRI may be useful, but larger lesions are required for visualization. Now, when we look at our patients and we try to decide how we're going to manage their endometriosis, we need to consider their age, what their symptoms are, what stage of the disease they have, and whether fertility is an issue. So typically the groups divide into two, one with the group that has pain and the others that are requiring fertility. So we try, when managing their pain, not to impact on fertility. Also, I think it's well worth mentioning to the patients that it's a chronic disease and it's not curable, and there is no one treatment that stands out above the others. So what do we do? Well, we can watch and wait, we can use medical or hormonal therapies, and also the surgical management. Okay, so when looking at younger women, we may employ expectant management, especially if the disease is mild, and then we may need to look further if pregnancy hasn't been achieved following a period of observation. The pain that patients get with their endometriosis can be dealt with using non-steroidals and opioids. The hormonal treatments that we typically use would be the pill, and we can take the pill, the combined oral contraceptive pills. We can use in a tricycling method where all 3 packets we run together with no 7-day break. Danazol has sort of really disappeared now as a treatment. Progestogens, whether the implants, the depot preparations or oral, can be used, and also the gonadotropin releasing hormone analogues can also be used over 3 to 6 month periods. Hormonal management is useful maybe in smaller lesions when they've been diagnosed at laparoscopy. There is a recurrence risk with them when using this type of therapy, and also can be used in patients where surgery is not suitable or is refused by the patient. The reality is the larger, deeper disease processes do not respond to hormonal management. Danazol, it's, as I said, not used as much anymore, and unfortunately because of the androgenic side effects, a lot of women don't like using it. Provera and other progestogens can be used, but on occasion this causes irregular cycles and irregular bleeding, which for many women isn't acceptable. Also might cause breast tenderness, fluid retention, and depression. Gestrinone is an anti-progesterone steroid, and it has a use, but unfortunately again it may cause deviant voice, hirsutism, an enlargement of the clitoris, so it may not be suitable. The pill, as I said, is useful for these patients, and it can be very good at maintaining them once you've diagnosed the disease. And the analogues, the gonadotropin hormone releasing analogues, can be used for 6 months typically, but you will get recurrence of symptoms, and this is usually used in conjunction with surgery and ahead of any fertility management. If patients have a lot of symptoms with their gonadotropin releasing hormone analogues, then we can use add-back therapy, which is basically HRT. And again, there isn't a major difference between these various treatment modalities, and it all boils down to what's most acceptable to the patient and what works best with them, and sometimes it's trial and error. So surgical management, well, it's conservative, where we excise or cauterize and burn away the lesions, or where we perform uterosacral nerve ablations, where again the evidence is fairly poor. Hysterectomy with or without the removal of the ovaries may be an option, and focused surgery on the ovaries may also need to be employed, depending on what outcome is needed. We know that laparoscopy is probably superior to laparotomy for most gynecological procedures, and endometriosis is no different. And we know that from a cosmetic point of view, recovery point of view, pain requirement point of view, etc., laparoscopy is the gold standard. There are various ways of treating the individual lesions, but as it stands, there are no large trials differentiating one from the other. Again, these are just images of how we excise some of these lesions. Now, what we find is that stage 3 and 4 disease responds best to surgical management. Earlier stages, stage 1 and 2, don't seem to respond as well. And I think probably the best means is surgery plus hormonal management. A Cochrane review from 2004 finds that there is no major role for medical therapy with hormonal medication, and that the best way to achieve pregnancy in the infertile patient who's got endometriosis is to ablate the lesions and try and return anatomy as close to normal or as previous. Intrauterine insemination may help patients overcome minor disease, and IVF then is required. Overall, this is a sort of a flow chart for what we use or what we look at when looking at these patients. If we're going to watch and wait, NSAIDs or the pill might be useful, but certainly surgery will come into play if there's been a failure with the NSAIDs. And if there's been successful treatment, you can keep these patients on. But I think in the background they have to know that the disease is incurable, and that we have to manage their symptoms as opposed to completely treat them. And again, when looking at infertility, the laparoscopy is the way to go, rather than using medical management. So that's endometriosis in a nutshell. Hopefully this talk has been useful for you.